Okay, so thank you for the lovely introduction. Today I'm going to talk to you about ways that we can think about reimagining how we approach science communication by applying a medical anthropological lens. I won't go through my introduction since he just did such a great job of introducing me. Instead, I'll just dive right into our topic. So first, I'm assuming everyone on this call has some mutual interest in wanting to communicate better. And I'm curious to know why we're interested in doing that. Is it because we believe that what we do is cool and the world should know about it? Is it because the information that we do research on, we feel is very important and we need to share it because it can help people? Or we don't need to improve our communication. They should just listen better and follow our instructions. One idea could be that we don't actually need to improve how we communicate, that people should just listen to what we say because we're scientists and we have this training that we know what we're talking about. That's one theory, and we've tried that, and we saw that that wasn't very effective in getting a message across. And so it's really important that we be mindful in how we approach communication, especially when we're communicating with people who don't come from the same background or training as us. And so I really like this quote because it kind of conveys that sentiment. The single biggest problem in communication is the illusion that it has taken place. And that's largely what we saw with COVID. We thought through different public health measures and interventions that we were communicating a message, yet we had large swaths of the population who are still not willing to receive that information or who still misinterpreted that information and thought we were trying to cause harm. And so it's really important that we master the skill of communication so that way we can prevent things like that from happening in the future. So this we would think would be easy. You know, we say we develop a therapy or a vaccine or something that can save your life. Why won't you take it? Why is conveying information that could be potentially life-saving so difficult? It's not that people are just stubborn and don't want to hear it. There's a lot of reasons that contribute to how they hear that message. One of many reasons is that we all come from different backgrounds, and those backgrounds shape not only how we choose to identify, but how we experience the world around us. And so when I say background, I'm not just talking about race and culture. I mean, even our academic background. We're trained to talk to people within our field, but when we try to cross disciplines and explain what we do, often a lot of our meaning is lost. We come from different socioeconomic backgrounds. And so what may be normal or accessible to one person may not be normal or accessible to another person. So we have to consider that when we start thinking about what we're trying to convey to people, what their level of access is and what their level of exposure is. We also have different lived experiences. And so that can affect how people respond to different information. Telling someone to go to a doctor when they've had previous bad experiences and with the healthcare system will not resonate the same way as someone who has not had those experiences. Also, how we identify and how people see us or don't see us will also influence how receptive people are to information or to following instructions. And so when we approach conversations, we have to take all of those facets of the people we're dealing with and of ourselves in mind when we're trying to get people to understand what we're saying and potentially even heed what we're trying to get them to do. And so this is just a comment to kind of reiterate that point about approaching conversations with empathy. As scientists, as researchers, as practitioners of medicine, large parts of our field and our training are focused on actually removing that attachment and dehumanizing our experience and our view of our samples, our research participants, our specimens, declassifying information. And so, you know, that helps us be objective in how we approach our research. But then when we want to go explain that research or share that research with the people that we intend to help with this research, we have to reintroduce that human aspect back into our communication in order for it to be well received. We can't refer to them with those objective terms and use that objective language and expect to have an emotional appeal. And so, how do you teach people who aren't trained in communication or empathy how to demonstrate or practice empathy? It's not the easiest thing in the world to do, and I don't have a clear answer, but I do have an idea of one way we can do it. So as we said in the beginning, my background is in anthropology. And what anthropology is actually the study of human cultures and how they exist in the world. And so what I'm proposing today is that we use some of the methods that have been established in anthropology for studying people and navigating cultural interactions and applying them to our biomedical conversations with people, just as a way to gauge or navigate how you begin to reach levels of mutual understanding, establish baselines, identify what the problems and concerns are, and making sure that you're addressing them when you speak. In anthropology, a lot of the foundational work is done in what we call ethnographies. And what that entails is spending long periods of time immersed in a culture or a micro environment that's different from yours. So a lot of times people think about going to far reach different areas such as remote islands or countries and things like that, and staying in these different types of environments. But it can also apply in modern terms. It can also be, there can be ethnographies done in your current environment just by taking a step outside of how you normally view something and looking at it objectively. And so the metaphor we typically use in the field for how to explain what anthropology is it's the concept of teaching a fish it lives in water. There's no way to explain to a fish that it lives in water because that's all it knows. It doesn't have any frame of reference for anything else other than water. And so by trying, and how we do that, we have to introduce an other. And by having that other is how we learn to not only identify them, but also to learn more about ourselves. We can't identify certain aspects of how we view the world if we don't have something to compare it to. And so a large body of work and a big portion of the premise of anthropology is coming up with methods of how we're able to convey that information or how we're able to do that. And so, yes, as I said, the bottom is trying to determine ways to better understand ourselves and others in different contexts. So taking a step back, when we think about the term culture, we tend to think about practices, behaviors, language, belief systems, and apply it in an ethnic sense. But it can also be applied in terms of occupations. It can be applied to institutions. And it can also have far-reaching effects in terms of, if we have different cultures and we perceive information differently and we communicate different information differently, then that could lead to misunderstandings that could affect people's outcomes. Over time, that could lead to disparities in those outcomes. It can lead to misunderstandings in how people experience illness or understand their illness. And so it's really important that we don't just reserve anthropological thinking for cultural understanding, but also think about how we can expand this definition and these techniques across our other fields. And I propose this because even though we tend to think about fields such as science and medicine as a purely objective and devoid of culture, they're actually not. Using that definition, we can actually describe science and medicine as their own microcultures. Both fields or disciplines share beliefs about how health and illness, the mechanisms work, how they present. They each have their own special language or jargon, ways we refer to things. There are certain ritualistic practices, such as for medical students, they have a white coat ceremony. They have different rites of passage within their training, such as getting a shorter length coat. And as they go through the process of becoming more seasoned in their field, that the length of the coat indicates a certain level of accomplishment. There's match day rituals. These are things that don't have any biological basis. It doesn't make you a better doctor if your coat is white. It doesn't make you a better doctor if you have a ceremony of it. There's no need to do a matching ceremony from a biological or strictly scientific purpose, but we do these things as part of a culture and how we pass along or train individuals and integrate them into becoming new members of that culture. There's also, with any culture, there are rules. There are ways that we expect doctors or researchers to behave. There's codes of ethics. There are things that are normalized. There are things that are not normalized. There are ways that you expect to be communicated to. There's language you expect to be used in a medical or science setting that you wouldn't necessarily expect in another setting. There's hierarchy. There's different roles of different individuals that all play a part in making this system work. There's routines, there's practices, and there's even trends in how we administer care that differ based on their local settings. So the way that we approach treating certain diseases and illnesses in America and North Carolina differ widely if you go across seas, if you go to other parts of the world, other hemispheres. And so a large part in how we communicate our views about medicine and science, we have to first acknowledge that there is a cultural influence to that. And so just because somebody does something different or interprets what we're saying different doesn't mean that they're ignorant, doesn't mean that they're stupid, doesn't mean that they didn't hear us. But we have to understand that from their worldview, from their culture, from their lived experiences, what we're saying may have a different application or meaning to them. And so anthropology or medical anthropology provides us a systematic way of how to evaluate how those differences can occur and how to begin going about addressing them. Just like with how we approach research and medicine can be culturally influenced, how we experience symptoms and illness is also very culturally influenced. Here I have an example of saying, ouch, when you get hurt. That's not a biological response. There's no rhyme or reason to why we do that other than we've seen it and we've observed it and we've been encultured into it. But that's an example of how we've learned to behave in response to injury. And there's plenty of other examples, but I just highlight this one because I think it's the most relatable in just terms of thinking about things that we often assume are norm, but aren't necessarily the norm for everybody. And so when we think about other ways that health and sickness can be culturally influenced, how we think about ourselves in terms of our body and the connection between ourselves, our body, our minds, our souls, how we define wellness, how we define illness, the types of things we consider to be illness. You know, in America, we have a high cultural value on appearance. And so we go about approaching things like acne or baldness with medication, whereas other cultures that don't value those features, you might not see as heavy medication or research or the same type of treatment to those same symptoms. We also have cultural beliefs about how someone should act and when they're experiencing pain or loss, what type of things you should suffer through silently, what type of things that you should be able to work through, what type of illnesses, sickness, ailments are things that you should take time away and how long you should allot for those different illnesses. All of those things are culturally defined. There's no biological definition of how long maternity leave should be. That's based on our cultural lens and how we value work and child rearing and family practices. If you look in different countries in Europe, they have much more liberal or extensive maternal leaves. They have paternal leaves. They have different views on vacation and what it takes to be an effective worker, or even how they structure their work days. All of these things impact our health. They impact our view of health and how we experience illness when it does present. So as I illustrated before with the example from COVID, poor communication, especially in the fields that we occupy, can have very severe consequences. Some of the more minor ones might be things like time. They can get more serious when it becomes resources, especially when we're talking about heavy funding for health interventions, developing vaccines, developing therapeutics, doing clinical trials, pilot testing, that scales up when we're applying for grants. It can lead to frustration if a person in the interaction doesn't feel like their concerns are being taken seriously, if they don't feel like they're being heard, if they feel like they're being talked down to or treated in a paternalistic way. And these miscommunications can cause tension in terms of when we're trying to reach resolution or cures or care or treatment of any sort, which can lead to prolonged suffering of the person. Over time, that could lead to feelings of demoralization, loss of hope or faith in the medical system, and also can affect their willingness to comply with medical advice or prescriptions. And ultimately, all of these things can affect the quality and quantity of life we have. And so because our field is so tangential to the field of healthcare, it's really important that what we're trying to do with communicating science is to effectively make people change their minds. If we're going to do that, we can't do that with the approach that we know everything and that we are the end all be all of information and people have to just listen to us. We have to first begin by listening what it is that they're actually concerned about, and if what we're offering to them is actually addressing that concern, and if not, how can we better do that? And so again, the field of medical anthropology supplies or provides frameworks that we can use to begin getting that information that strictly using biomedical approaches don't provide. So one of the things that I would heavily emphasize for us approaching conversations as scientists, as people coming from academia, as people coming from socioeconomic brackets that afford us different privileges that others may not have, is that when you're talking to somebody, even if you're saying something that may come off or that to you may be innocuous, just the differences in your social positions can impact how people perceive you. So to revisit our COVID example, when we think about how a lot of the discourse was about minority populations not wanting to trust the vaccine or not wanting to utilize the vaccine when it's available, when you think about that in its setting, you think about communities of minorities who have experienced deficits in healthcare and resources for decades, centuries. And then you have people who are not part of these communities coming in and telling them what they should or should not do and expecting them to just take that information as true and then wondering why it didn't work. So understanding that even if you're trying to do what your intention is pure, that power dynamic can still be off-putting or even intimidating to people. And so we have to be mindful when we talk to somebody, just making sure that we integrate normal aspects of human communication, eye contact, pauses to allow people to process the information. How are we standing when we talk to people? Are we hovering over them? What type of words are we using? Are we giving them opportunities or introducing opportunities into the conversation to gauge their level of understanding? Do they feel comfortable enough to express if they don't? Do we get frustrated if we were asked to repeat ourselves? Things like this can impede effective communication. Also, the assumptions people may have about the person they're communicating with or the person doing the communicating can also impact how that message is received. And so I like this quote by Foucault that references what he terms the clinical gauge. And it embodies a lot of how we approach medicine in the Western Hemisphere, and that a lot of times as medical trainees, people are taught to perceive the patient not as a human, but as a body with just interchangeable parts that are experiencing symptoms. And so we tend to hyper-focus on the problem of that body part and not how that problem impacts that individual in other aspects of their lives. And so if you're trying to get somebody to want to take invested interest in what you're trying to communicate, if you want them to follow instructions, if you want them to understand or participate, or feel trusting in you enough to communicate their fears, concerns, or misunderstandings, then you have to do a pulse check. You have to think about who you're talking to before you start the conversation. You need to try to understand what their background is. Or is this a topic that they're familiar with? What is their how are they familiar, or what is their exposure to this information? Is it something that could be triggering for that person? Is it in a setting that could be perceived in any other way than how you intend it to be? Does that person care? A lot of times we get so excited about what we do because we do it day in and day out. We spend a lot of time in our research at home, in labs, doing interviews, in different methods, learning, being trained in these methodologies that we assume everybody is going to be as invested in it as us. But not everybody cares about T cells. Not everybody cares about what we do. And we have to acknowledge that that's fair, and and think about ways to communicate in ways that will be of interest to them. So figuring out a common ground. Also, if they're coming to you and trying to get information, truly understanding their question. Sometimes we, as scientists, we hear one thing or we see somebody and assume we know what they're trying to get out of us. And a lot of times we may be missing the point. A lot of the communication or miscommunication that happened regarding the vaccine, some of the questions that people were asking weren't expressing their distrust in vaccines. They were expressing legitimate concerns about side effects that we don't have answers for, or other factors that are specific to their lives in the context in which they would be taking it. And so as scientists, even though we may assume that we know what someone's trying to ask, it's really important that we take that pause and let them explain what they want to know and ask follow-up questions to make sure that we're following what they're trying to convey. One of the frameworks that's been largely utilized in medical anthropology for trying to discern this information in both research and medical settings is categorizing different approaches as biomedical model versus the biopsychosocial model. So when we think about biological models of medicine or research, it's probably the one that's more familiar to us as scientists or medical practitioners. It's the view that focuses on the disease and the symptoms and everything that we consider to be objective, I guess, about a person. So things like their age, their gender, their symptoms, things like that, but specifically limited to the context of that individual and that ailment. When we expand how we view illness, medicine, treatment to encompass the context in which those symptoms are situated, using a biopsychosocial model, we not only pay attention to the medical presentation of those symptoms, but we also consider how they affect the individual at large. How does being sick or having a chronic illness affect someone's mental health? How does it affect their emotional health? How does it affect how they believe or trust in the medical system if they have a condition that's not treatable or doesn't have a long-term cure? if their symptoms aren't managed, if they're continually going to the doctor, but they're chronically in pain, despite, how does that affect their ability to have faith in the medical system? How does this affect their social interactions? How does it affect their interactions with caregivers? Are they able to go to work? Their quality of life? You know, just being sick is one aspect of a person's experience, but people are so much more, and their interactions greatly magnify how their experience or how they feel affects them and their ability to move through the world. And so one systematic way that's been introduced, it's been championed by a medical anthropologist and psychiatrist at Harvard Medical School named Arthur Kleinman. And he's one of the pioneers of trying to figure out ways to address the holistic being in Western medicine. And one of his theoretical models that he's introduced is called the explanatory model. And it's basically just a list of questions of which physicians can use when dealing with patients to try to get at some of that cultural nuance that may be missed in a normal medical interaction. And so asking open-ended questions that allow for the patient to introduce information that we may not consider from our vantage point. Things like, what do you think caused your problem? Asking an open question like that can get a patient to reveal information that if you just ask them yes or no, or limit yourself to a questionnaire, may be missed. Why do you think the problem started? What does the sickness mean to you? How does it affect your work? How severe is the sickness? And what are your views about it? There's a large body of research in medical anthropology surrounding what we call the placebo and the nocebo effects. And what that addresses is how a patient's perspective or view on their illness or the effectiveness of their treatment, the potential of their treatment to be effective influences their outcome. Just by having a negative mindset can actually negatively influence how that person responds to medicine. And that's been shown in studies for decades. The same goes with a positive mindset. When someone has true faith in the therapy or the practitioner, how that can also affect the outcomes or their willingness to participate in the recommendations that are given. You can also discussing different treatment options. Just because there's a standard treatment for a certain ailment doesn't mean it's the only way. And when there are options, some may be more compatible with a person's lifestyle or belief system than others. So introducing that type of question into the conversation, make sure that you're doing something that the person is more likely to feel comfortable with and likely to comply with. And so this list of questions is a bit exhaustive, but it's intended for practitioners. While as scientists and researchers, we may not necessarily need to ask these specific questions, we can shorten this list to ask more pointed questions that get at the problem. Yes?
I'm going to need you to wrap it up in the next minute or so that we can transition to the next speaker, please. Thank you.
All right. So some of the benefits. So basically what you're trying to do is gauge the problem, gauge the background, and gauge the level of interest before entering conversations. And so using a medical anthropological approach, some of the benefits are that we have a systematic way of doing this. And also you reduce the risk of misunderstanding, and you can have these conversations in a way that's void of judgment, stigma, or shame. So some of the takeaways I hope that you got from this talk is to appreciate the role that culture plays in every aspect of our communication, even the ones that we believe are objective and devoid of culture. And with that, I'd like to thank you for listening.
Thank you, Dr. Daniels. Very helpful information. And we'll open it up to questions at the end. Dr. Eily, I'd like to turn it over to you, and hopefully you'll be able to share your screen as well.
I'm going to preface this by saying I have been sick for the last few days, so I am going to try and be brief and to the point. But kind of my main thrust is, how do we figure out how to communicate our science effectively, particularly in the guise of doing interdisciplinary work? And so, again, I won't spend too much time talking about me, but I am going to focus on the work that I did in my postdoc, looking at how we communicated risk and worked between different research groups while I was working for the North Carolina PFAS testing network, as well as working for the interdisciplinary grant that I was running, or the STEAM initiative. So looking at STEM plus the arts and the humanities. And so With the PFAS network, this was a group of 7 different universities across North Carolina, organized into different research pods, essentially. And so our work on the communication team was to figure out, how do we ensure that all of our scientists in each of these different research groups from all of these different places are able to effectively communicate with each other, effectively communicate with communities that are impacted by this problem, effectively communicate with policymakers, regulatory agencies, as well as the industry folks who were putting these different pollutants in the environment. And so a lot of work that we did was training our scientists how to articulate their research to these different audiences, as well as providing means of communications from the research network or the testing network itself in a public-facing way. And in the STEAM work that I did, it was really about, how do we take at Duke the ability for us to make all of these different interdisciplinary collaborations, and how do we find ways to do this effectively? What are the kind of barriers that help us from seeing the different ways that our disciplines can come together, as well as what goals we can kind of pull out of pulling these different disciplines together? And so this was one of the quotes that came from one of the students who was at the symposium we did on interdisciplinary work, that likened math to fiction writing more than anything else. And so there are so many different ways that you can open the door to creative thinking when you can figure out how to communicate your work effectively to different spheres. And so I'm going to focus on how we kind of boil this down to 4 main steps for how to communicate if you're thinking about, I want to start forming collaborations with other people who are doing different research than me, or I want to present my work to different audiences. And so the first thing that I want you all to do is, I want you to take a moment, and you can put this in the chat if you want to, but I want you to think of, who is it that you would want to be communicating with, right? What will be the purpose of you taking this training and then applying it in your own sphere? So who would that person be? What do they do? What's their knowledge base, and how's it different from your own? And so take just a moment and think about and envision that for yourself, because we're going to come back to this with each kind of step that we do along the way. And so you can give me a thumbs up after you've got some stuff in the chat for us to move forward. So I see we've got policymakers, clinical scientists. So as we keep going, I want you to keep coming back to, who is it that you would want to be communicating with? And so this really can be boiled down to 4 different steps. The first of which kind of is centered on the fact that from our science backgrounds, when we're presenting this work to other folks, the way that we think about our work, the way that we write patients, the way that we describe things, we very much get into the weeds and the nitty-gritty details in our way to making this kind of finite point. But when we're presenting our work to others, we kind of have to flip that on its head and present our point first. We have to make sure that who we're communicating to understands, why is this important, and why is it important for me to be talking to you about it in particular? And so this requires us to kind of step outside of ourselves to be able to think from this other point of view. So I'll take the example of policymakers. What is it about the work that I do that policymakers would need to know, and why would that matter to them? So the first thing being is that you need to figure out what your message is for the audience that you want to talk to. And so whatever that message may be, it needs to be something that's easily understood, something that's memorable, that when they walk away from that meeting and any of the other meetings that they have had that day, they remember what they spoke to you in particular about. It needs to be focused, and it needs to be framed so that it's relevant to your audience. And so when we're thinking about how we craft our message, whatever that central idea might be, so in the case of the STEAM work that I was doing in my postdoc, that might be that interdisciplinary collaborations are really powerful tools. And I can frame that central message in a lot of different ways and adorn it in different ways. But if I don't communicate in a way that that message gets across, then the people I'm speaking to aren't ever going to get what that message is. So the sooner you can identify what's the thrust, why does it matter, what am I trying to communicate to this audience, the better off you'll be, regardless of who that audience is. The second piece of this, right? So as we're thinking about those different folks, and you can pop this in the chat as well, you can be thinking, what might be the message I want to communicate to those different individuals, policymakers, clinical scientists, whomever it might be. And you can add those in the chat as well, or just keep them in your notes as we're kind of moving along. And I'll provide kind of a space for you all to continue doing that as we go. And so after we kind of have what our message might be that we are sending or sharing to our different audiences, we need to think about very particularly who is the audience that we're talking to. And Dr. Daniels talked about this as well, in thinking about who it is we're speaking to, where they're coming from or what their background is, figuring out how best to address them or acknowledge them, what their knowledge base might be, finding places where you have commonalities. And in the kind of realm of doing interdisciplinary research, one of the things that's really important in thinking about your audience is thinking about the why are you talking to these folks, right? What's your goal for this interaction with them? Because the sooner that goal or expectation is kind of laid on the table, the sooner you can be sure that you are communicating in a way that is actually aligned instead of misaligned. And so I liken this to an experience that I had in grad school. I was in DC meeting with different policymakers for North Carolina, and we were in a meeting with one of our Republican congressmen, and we were talking about open access to scientific research. We focused solely on the fact that scientific research needs to be open access from an academic setting, right? The boon of having all of this knowledge accessible and the fact that it can speed up research and innovation. But there was this moment where one of us mentioned the economics of open access research versus how we pay for access to research papers now. And that was the thing that actually mattered to the staffers in that congressperson's office. And so making sure that you know who your audience is so you can frame what your message is, right? The message was the same. Open access to research is important, but the framing about it wasn't actually structured in a way that was aligned with the congressperson we were speaking to. And so having that goal and having extra knowledge about who it is you're speaking to can drastically change how your message is received when you're communicating. And in interdisciplinary collaborations, that matters a lot because we all are super busy and we all want, if we're starting a new project, for example, we want that to be able to get off the ground. And so if we can align our communication, we can actually start that timeline a little bit faster. And so in your brainstorms, you can kind of think, well, what would be some additional details about the audience you might be communicating to that you would want to know or ask questions about, or what might your goal be heading into the communication you would want to start with these different individuals. And so this audience component also becomes particularly important when we shift into thinking about what are the actual means of communication we need to use as we start crafting our message to present to these individuals. And so one of those big things is ensuring that the language that you use is accessible. Each of us in any discipline that we're in, we have a specialized language or jargon that we use to describe things in our discipline, right? Depending on what that discipline is, you can have an alphabet soup of different acronyms that you use for things that you know like the back of your hand, but depending on what group you're moving into to share, those things don't necessarily translate. And so if you are speaking, your message gets lost because every time you drop one of these jargon words, it essentially acts as a roadblock, preventing your audience from being able to be aligned with you as you are communicating together. And so figuring out what those different complex or jargon terms are and finding ways to explain them becomes really important. And it helps you kind of smooth out, okay, if I'm presenting this work to a Congress member, what are the things that are essential, right? What are the complex terms that are essential for me to communicate? And can I find good ways to explain them versus just kind of going at it fully immersed in the language that you used all the time, and then losing them while you're engaging in that communication. And so we don't always need all of the big jargon that we use, but if there are certain terms that you absolutely have to use, when you reduce the other jargon you're using, there's actually breathing room for you to explain what that essential term means and why it matters for that person to understand it as you're having that conversation. And so when you're thinking about this, kind of taking a moment to even just a thought bubble of, okay, these are the different terms that are going to come up while I'm discussing this project or this work with this audience. And how might these terms be a barrier? What things can I translate versus what things are essential? And so you can kind of think that out and map that out for yourself to help you as you're crafting your message. And you can also think kind of conversely from the, like, whatever audience you're presenting to, they're also going to have jargon that they're coming into that conversation with too. And so there might be some terminology or things that pop up that you might need to ask them about as you're communicating, and that's okay, because the whole point of this communication is to create a two-way engagement between the two of you. And so there should be some space for questions, right, and engagement. And so the fourth step in all of this, as you're kind of speaking and interacting, is to find some means of actually capitulating what you're trying to say in the structure of a story. So as human beings, we learn very well off of hearing stories, reading stories, etc. It also helps create this self-contained two-way interaction that kind of centers on the audience or the listener that you're speaking to, right? And so by using different storytelling devices as you're trying to communicate your scientific method, this can strengthen what it is you're trying to get across to that audience. That's why so many different researchers that are biomedical focused, right? You center on stories of the people that this disease is impacted by. And so figuring out how you can use story to support your message can be really important. And it doesn't necessarily have to be a fully thought out hero's journey story, but you can find different story or literary devices. Like, we use metaphors and analogies constantly when we're trying to explain different scientific topics to others. And so kind of developing what are the ones that I can go to that make the most sense, but also help drive that one central message home are the priority here. And so I'm going to go through a couple different storytelling frameworks that you all can use to kind of help you as you're thinking about doing this. And so we can boil it down and shrinking whatever your scientific story might be to its core, either by thinking about it in one word, one sentence, or one paragraph. And so there are two different story formats that I'm going to introduce, and these come from, it's used commonly in theater trainings or improv training, but these also come from a book called Houston, We Have a Narrative, which, if you're interested in science communication and the use of storytelling, is a really great book. One is called the Dobzhansky template, which essentially is nothing in blank makes sense except in light of blank. So you figure out what are the two essential things in what it is you're trying to communicate and how do they link together, right? So it could be, I did my PhD work studying symbiosis, so it could be something like, nothing in symbiosis makes sense except in light of communication, right? Those two organisms need to be able to communicate with one another to engage in that symbiosis. So that's one word template or story template you can use. And then the other one, which is a little bit more fleshed out, is essentially a 3-act story, or the ABT template: and, but, and therefore. And so the and is essentially what's all the background knowledge that you need to share, what's the exposition. I see some of this got cut off in the way this picture was edited. The but essentially gives you what is the problem that has been introduced. And then the therefore helps introduce how could we possibly start solving this, right? How can you participate in us solving this problem? Or what is it that we need to do together to solve this problem? And so those are just kind of templates that you can play around with as you're thinking about how do I communicate and share this message to different audiences, and what are some structures I can use to organize my thoughts to get better engagement when I'm sharing this across different disciplines or to different people in different audiences, be it policymakers, physicians, patients, etc. And so again, kind of some space to think of what stories or things you think you could use to help you explain your work to whomever it is you might be thinking of communicating with. And so with that, I kind of like to wrap up with this. Sometimes when we think about storytelling for the science that we do and the rigor that we approach our work with, we can feel a little squishy with it. But in general, in life, it's lots of tangled threads all over the place. And as scientists, we are trying to neatly and orderly put them in some kind of framework that makes sense. But storytelling isn't changing the thread of what is actually happening in reality, but it does help us shift it in such a way that whoever our audience is can kind of snuggle up to it and really get to the core of what it is that we're trying to share with them. And so I try to do this as we're not changing the thread of the work that you're doing, the science that you're doing, by using storytelling as a device to share that work with different audiences. And so overall, have one clear, consistent message that's relevant to your audience. Think about who that audience is in as much detail as you can and what the goal is of you communicating with this particular audience. Be really sure to be clear with your language so you aren't introducing roadblocks, and help assist them with roadblocks that are essential. And then see how you can use story elements to help connect you with your audience and make your work make more sense. And so with that, we will hopefully have plenty of time left for questions.
Dr. Eily, thank you for your presentation, and Dr. Daniels, thank you again for your presentation. They were certainly a nice kind of dovetail to one another, where Dr. Daniels started with helping us to all remember that it's important to think about the context and the worldview and the lived experiences of the people that we're communicating with. And then Dr. Eily really helped us to think about focusing on who we're communicating with, also considering all those points that Dr. Daniels helped us to kind of reestablish in our mindset. And so I'll open it up to the audience for questions or comments or guidance.
I don't know if you guys can hear me.
Mm-hmm.
Go ahead, Jamila.
Hi, this is Jamila Taylor. And this, I guess, is pointed more towards Dr. Daniels.
You're on mute.
Jamila, we just lost you. We don't hear you any longer. Jamila, we can't hear you.
Looks like a really good question.
It does. Jamila.
This is better.
Oh, there you go.
All right. Thank you. I'm a running back. I didn't get very far. So really quickly, the question is, I guess, in terms of what you mentioned for clinical gaze, in the setting that you were talking about was more, I guess, of a clinical setting, but kind of expanding that or extrapolating that back out in terms of like dissemination, or even really engaging the patient population with any kind of implementation. How do you maintain that kind of engagement, even if you're trying to, use language or know your audience, just because of the relative difficulty of a topic or the lack of just general, if you're not in the science setting, it's just not very exciting to you, but it's, it's important. So how do you either establish or maintain that engagement, either in an in-person setting or any kind of dissemination or implementation, if possible?
Great question. So a couple of different ways you can approach that, especially as scientists when our research can be very niche. Like, I'm sure 2 people read my dissertation and they may or may not have been on my committee. One thing I was taught when I started, or not taught, but I went to a panel and I heard that really impacted me greatly, is if you can explain it to a kindergartner, you can explain it to anybody. And so this was a woman who worked in like business for some industrial company, but she got her position because she started volunteering at a children's museum, explaining how she did genetic engineering. And so it's one of those topics that we tend to think of as like, you know, how do I explain this to a regular person? There's no possible way I can do that, but there is. I mean, the concept of fixing a mistake is something that we can all relate to. So I often resort to metaphors, and I also followed her example. So I volunteer at the Museum of Life and Sciences, and I explain vaccine development to kindergartners and 3rd graders and everything, and they understand it. So sometimes not just breaking it down to that level, but also making it that accessible. I realized with a lot of my outreach work during the pandemic, messages weren't being well received by adults about vaccines. And a lot of the reason was because they were scared to ask questions that they thought were stupid or basic. But what I realized is in that setting, when I was doing these demos of little kids, and the kids are asking questions and they're coloring, I have like tactile activities for them, the parents would be sitting around. So I would make sure to have information for the parents that was accessible. And a lot of times they would use their children as a gateway to get some of their questions answered. So I'd have parents coming up to me and saying, well, Timmy wants to know what happens if a cell eats another cell. And it's very clear that Timmy doesn't care about that, but the parent did. And, you know, it's a question I'm sure has been burning that person's mind for so long, but never felt comfortable approaching someone to ask. Like, you don't want to go up to your doctor and ask something that you feel is such a basic question. You don't want to go up to a scientist and ask that. But in a setting that was just completely devoid of judgment, I mean, it was just super casual. It was easy for me to ask that question. And how I addressed that question wasn't didn't you ever take biology? I didn't do that, but I was like, actually that happens all the time. Cells eat other cells. It's part of how our body keeps ourselves safe, and just through that point of like, creating a space that someone felt safe enough to ask what they were actually concerned about, we were able to have a much deeper conversation that started out with a simple question and then ended up deep diving into his concerns about vaccines. And so just, I would say, making your message, distilling it, making it really, really simple. We overestimate what a simple message is because we're trained to talk to other people who do science. But to a lay person who hasn't taken biology since 9th grade, simple can't get simple enough. So just making sure that you really distill that message, you make yourself approachable, face posturing, try to reserve the kind of facial expressions and just be really open to what they want to ask. Because if I had initiated that conversation, I would have assumed this person was scared of something completely different, not because they didn't understand how cells work. And so, listening first to what the person is actually concerned about and then steering the conversation from there as a launching point. I hope that helps. I don't think there's a straightforward answer, but those are techniques I use when I communicate.
No, that was very helpful. Thank you.
Mm-hmm.
I just wanted to make one comment that Dr. Eily mentioned about how all of us as scientists live in the weeds of our work and the details of that and how we feel like we have to explain everything in the details because that's what makes sense to us. But when we're communicating with others, how she said to flip it, where we really have to start with the main point first. So that was really impactful for me. And I know I will think about that more often now when I'm trying to communicate to other people that really we do need to get out of the weeds and then just go higher up. So thanks for mentioning that. That was really useful.
What other questions do we have for Dr. Eily or Dr. Daniels?
Maybe one challenge or one question if nobody else has any, I guess, what are some common challenges that either of you have faced or some unique challenges that either of you have faced and ways that you kind of got around it in terms of either communicating directly with patients or colleagues or communicating, through other medium, whether it be, journal articles or presentations like this or anything of that nature, just in terms of trying to get the message across.
Yeah, great question. I think one of the things that I have seen in training scientists to communicate, some of the common pitfalls I see are one, trying to anticipate and explain everything. And that and that's why I kind of harp on, find the one message you want to share and distill what you're trying to share to that one point, because you can always add more, right? If they always have space to ask you questions about things, but if you try and anticipate every single question and then put the answer to every single question they might ask in the communication, then that overwhelm is actually going to prevent them from being able to ask you questions. So don't feel like you have to put everything out there. There's always room for you to follow up and for them to ask you questions, for you to share more details. So that's one. And I think a second one is when we encounter that point where we actually don't have the answer yet, and we get really kind of squirrely and uncomfortable because we don't know how to respond. And this is something that I saw with the scientists with the PFAS work that I was doing, because so often people, the number one question people in the public had was, is it safe to drink is it safe to drink the water coming out of my taps in my home? And we were still in the process of figuring all of that stuff out, figuring out what the levels were that were in the water, et cetera. And so scientists continually got frustrated when they were asked that question, because they were like, well, the research hasn't told us yet. And figuring out how to answer, one, how to say we don't know, while also giving people a means of empowerment is really important. So one of the things that I started coaching them on is, okay, yes, science might not have the answer yet for how much PFAS in particular is in their water, but you can explain to them how you might go about making that decision and what information you might want to take in so that they can do that when that information starts becoming available. So it leaves them like, okay, science doesn't have an answer yet, but once we start getting that information, they now have the power to do something with it because you've helped them figure out how. So even if science hasn't reached the point to give an answer, you can gift them your scientific thinking so that they can find an answer later. So those are two kind of big pitfalls that I see most often.
Dr. Eily, those were great recommendations. And Dr.
Great.
Daniels, your comment about it may sound overly simplistic, but drilling it down to a kindergartner. I was recently in a situation where I was trying to explain my research to somebody, and I thought I was doing it really easily. And I just got a bunch of fuzzy faces looking back at me. And I was like, well, they're not receiving my message. And it just reiterated, keep it as simple as possible and engage them. And as Dr. Eily said, allow them the opportunity to ask more questions. And those are really good take-home principles for all of us. To both of our presenters on this Monday afternoon, a heartfelt thank you from Duke Center for AIDS Research. We're very appreciative of your wisdom and insight and time, and thank you for coming back to Duke to share your perspectives. In the new year, we will continue our conversation series about how to disseminate our research. And so we thank everyone for their time this afternoon, and we thank our two speakers for their expertise and wisdom and wish you all the best. And to our CFAR colleagues, we'll see you in the new year. Be well, everyone. Have a good week. Thank you.